Hello, everyone. Good afternoon, good morning, whichever appropriate time of day greeting applies to you in your time zone. We're going to move to get started. My name is Christine Camilleri, and I am a senior planner with Change Lab Solutions. And I will be moderating the discussion portion of today's webinar. I'm really just delighted to welcome you all to the second episode of our webinar series, which is titled Meeting the Challenge, Evidence-Based Policies to Support Children's Mental Health and Well-Being. Today, we'll be discussing workforce and healthcare opportunities. And just before we jump into setting the stage for our panel discussion today and sharing a bit of context, for those of you who may not know us, Change Lab Solutions is a nonpartisan, nonprofit organization that uses tools of law and policy to advance health equity. And we partner with communities across the nation to improve health and opportunity. And we do that by trying to change harmful laws, policies, and systems. We have an interdisciplinary team that works with community organizations, governments, and local institutions to design and implement equitable and practical policy solutions to complex health challenges. With that kind of context background on Change Lab Solutions shared with you all, I'm going to turn it over to my colleague, Liz Olson, for some housekeeping items and to share a bit more context for today's discussion.
Thank you so much, Christine. And thank you everyone for joining us today. We're really pleased to have you with us. My name is Liz Olson, and I'm a senior policy analyst with Change Lab Solutions. As Christine mentioned, I'm going to cover a bit of housekeeping and offer some context for today's discussion before we dive in. So we always offer the disclaimer that the information provided in this webinar is for informational purposes only and does not constitute legal advice. Change Lab Solutions doesn't enter into attorney-client relationships. We'd also like to acknowledge that this training was made possible in part by a cooperative agreement with the Centers for Disease Control and Prevention, and that the views expressed in this training don't represent the official policies of the U.S. Department of Health and Human Services. Okay, and with that, children's mental health is an essential component of their overall health, affecting how kids cope with stress, build relationships, learn at school, and operate in their broader communities. Although mental health and physical health are equally important and deeply interconnected, many kids and families are unable to access timely, effective, and culturally responsive mental health care. Additionally, while rising rates of mental health challenges predate COVID-19, heightened stress, grief, social isolation, economic insecurity throughout the pandemic exacerbated these challenges. According to the National Survey of Children's Health, among children birthed to 17, there were significant increases in children's diagnosed anxiety and depression, as well as decreases in caregiver mental and emotional well-being between 2016 and 2020. In the face of growing behavioral health challenges among young people, there are many evidence-based policy options that decision makers can pursue to equitably promote children's mental health, especially for kids with disabilities. We're excited to explore some of those strategies in this webinar series. So today is the second of a three-part series supported by CDC. This series brings together researchers, federal partners, national leaders, and Change Lab Solutions staff to discuss policy options that promote children's mental health. The first episode of this series, which is available as a recording on our website, explored income and housing. Today's focus is workforce and healthcare, and the third episode will focus on education. Today's discussion will highlight policies to expand the children's behavioral health workforce and improve the broader healthcare system's ability to respond to child and adolescent mental health challenges. Our panelists will share strategies to support master's level licensed behavioral health providers to enter and remain in the field, opportunities to grow the workforce through state Medicaid and children's health insurance program CHIP policies, and insight into healthcare and payment models that improve access to care. We know that healthcare interventions, while vital, will not on their own end the crisis in children's mental health. Upstream approaches that address the conditions in which children and their families live, learn, and play, and the inequitable distribution of power and resources that shape those conditions are necessary to ensure that young people have the support they need to be healthy and well. So we hope you'll join us in May, thinking about some of those more upstream approaches for the third session in this series, where we'll explore connections between the education system and children's mental health. So we are thrilled today to be joined by a panel of experts, all pictured on this slide. Christine will introduce all of them in a few minutes, but it's my distinct pleasure to first introduce Lara Robinson. Lara is a behavioral scientist with the Child Development and Disabilities branch in the National Center on Birth Defects and Developmental Disabilities at the Center for Disease Control and Prevention. As lead of the Applied Research and Evaluation team, she oversees research, programs, and evaluations related to improving health and well-being for individuals with attention deficit hyperactivity disorder and Tourette syndrome. I'm going to pass it over to Lara now, who's going to offer some opening remarks from the CDC team that has been leading this work. Lara, thank you so much for being with us today.
Thank you. I'm going to talk very briefly this afternoon on healthcare and workforce policy levers to improve child health. My disclaimer states the findings and conclusions are my own and do not necessarily represent the official position of the CDC. CDC recognizes the importance of identifying policy levers that improve access to healthcare for children. We funded Change Lab Solutions to analyze current policies and develop tools to increase the use of evidence to inform decision-making about policies that improve the health of children. As Christine mentioned, economic stability, housing, and education policies are the focus of other webinars describing our shared work with Change Lab. Specifically, our team's work centers on public health approaches to support the health and well-being of individuals with attention deficit, hyperactivity disorder, ADHD, or Tourette syndrome. So in the next few slides, I'll give some examples of how our policy work with Change Lab Solutions is related to our populations. Data from the Health Resources and Services Administration on the left of this slide projects the demand for behavioral health care will continue to far exceed the supply over the next decade. These trends for marriage and family therapists are similar to other behavioral health care providers and have implications for the treatment of children with ADHD or tic disorders. Although the American Academy of Pediatrics recommends behavioral therapy first for children under 6 years of age and medication and behavior therapy together for children 6 years and older, data from the 2022 National Survey on Children's Health indicate that less than half of children with current ADHD received behavioral treatment for their ADHD in the last year. Policies with the potential to expand and support the workforce for children's behavioral health through state licensure systems, state Medicaid programs, and the Children's Health Insurance Program can provide opportunities for increasing access to care for children with ADHD, and you'll hear more about them today. They can also increase access to care for those with Tourette syndrome who rely on behavioral health providers for their evidence-based tic treatment, such as comprehensive behavioral intervention for tics or CBIT. Integrated family care, a two-generational behavioral approach within pediatric primary care that treats the family rather than the child alone as the unit of care, may provide an opportunity to screen, identify early, and make referrals for both child and parent mental health needs. These alternative healthcare models can help increase access to care for children with disorders like ADHD and Tourette syndrome. Data from 2 recent meta-analyses on ADHD risk factors from CDC colleagues indicate opportunities for prevention and intervention at the parenting and family levels to decrease the prevalence of ADHD symptoms, the severity of those symptoms, the likelihood of meeting diagnostic criteria for ADHD, and/or impairment associated with disability among individuals with ADHD. Therefore, strategies to support parenting by promoting parents' physical and mental health, both prenatally and postnatally, through integrated family care can be an important lever to promote positive outcomes among children and families. Nearly 1 in 9 U.S. children have ADHD, but prevalence estimates vary widely by state. Some state Medicaid programs have implemented policies to manage the use of ADHD medications and guide physicians toward best practices for ADHD treatment in children. Prescription medication prior authorization policies are requirements that restrict approvals to patients of a certain age or require additional provider involvement before approval for payment is granted. We worked with ChangeLab Solutions and Temple University to develop a publicly available Law Atlas legal data set on Medicaid fee-for-service policies, and also a 5-state managed care organization pilot of ADHD stimulant prior authorization policies for children through April 2023. Using these data, the map on the left of this slide shows 34 state Medicaid fee-for-service programs have prior authorization policies for ADHD medication prescriptions that restrict by age. Understanding the impact of these policies on outcomes for individuals with ADHD can help inform best practice decisions. As you can see from the 2021 Meritive Market Scan healthcare claims data, across insurance types, many children and adults with ADHD get outpatient healthcare via telehealth. Access to telehealth was expanded during the public health emergency. And to better understand the impact of state policies that influence the quality of care provided via telehealth for individuals with ADHD or Tourette syndrome, we're working with ChangeLab Solutions and George Washington University to explore the literature, talk with subject matter experts, and identify state case examples of quality telehealth practices. This work will allow us to create resources for decision makers to better support policies that increase access to quality telemental health care. Now that I've described why these policies are important levers to support the individuals we serve and why we invested in this work, I'm going to hand it back to Liz and Christine, who will facilitate a broader discussion on some of these policies and how they can support access to behavioral health care. Thank you.
Thank you so much, Lara. Before I hand things over to our panel, I want to zoom back out for just a moment to describe the workforce and healthcare-related challenges that our panelists' work is seeking to address. So despite the growing rates of mental health challenges that we've described, children face barriers to accessing quality, timely, and culturally responsive behavioral health care. Analysis of data from the 2016 through 2020 National Survey of Children's Health found no significant improvement in receipt of mental health treatment or counseling over 5 years. And as of 2020, just 80% of children who needed mental health care received any services. Along with other barriers like and underinsurance and the high cost of treatment, a shortage of behavioral health workers is undermining children's access to needed care. The Health Resources and Services Administration estimates that 122 million people in the US, more than 1 in 3, lives in a mental health professional shortage area. Providers equipped to treat children and adolescents may be even more limited. In many cases, Families may have to travel long distances or endure lengthy waiting lists before they're able to connect with a provider. Workforce shortages are especially common in rural areas, and reflecting the impact of structural racism, research also shows that Black, Indigenous, and other people of color, as well as people with low incomes, are less likely to have mental health treatment resources in their communities. Of concern is not only the number of providers, but also the quality of care those providers are able to offer. To promote successful outcomes, behavioral health treatment should be both developmentally appropriate and culturally responsive, so that young people receive treatment that reflects and affirms their unique cultural and linguistic contexts, needs, and experiences. Healthcare systems more broadly can also pose challenges to children's access to behavioral health services. Families may face difficulty navigating sometimes complex and disjointed systems of care, wherein mental health is often treated separately from physical health, and children are often treated separately from their families. This can lead to delays in accessing care, miss important connections between each domain, or overlook underlying conditions that are shaping kids' health outcomes. Healthcare systems' prevailing payment models that pay providers based on volume of services they deliver, rather than the quality and efficiency of those services, also may not incentivize prevention, early intervention, and integration of behavioral health care. Today, our panel will discuss a range of policy options that may address these barriers and improve access to behavioral health care for all kids. I do want to preview that some of the work our panelists will discuss is reflected in a new suite of resources now available on the ChangeLab Solutions website. These materials specifically examine opportunities to address behavioral health workforce shortages through state licensure systems and state Medicaid and CHIP policies. Our team also just published an article in the Psychiatric Services Journal on the work related to licensing policy. My colleague Heather Wong is dropping links in the chat, and we'll share links to these resources during the webinar. I'll note that this suite of materials has a focus on the supply of master's level providers, including licensed clinical social workers, licensed professional counselors, and licensed marriage and family therapists. We focused on this particular segment of the workforce because LCSWs, LPCs, and LMFTs are among the largest occupational groups of behavioral health providers, require fewer years of schooling than MD and behavioral health and PhD level providers, and can provide long-term treatment, and they play a critical role in delivering therapeutic services for common behavioral health concerns among kids. While we maintain this particular focus in this recent work, it's worth noting that the full spectrum of behavioral health workers, school counselors, child psychologists and psychiatrists, and more is needed to meet this moment. So with that, let me hand things back over to Christine, who will be moderating today's discussion.
Thank you, Liz, and thank you, Lara, for helping to set the stage for our discussion today. I just want to make a quick note before I move us into the panel discussion. I think there may be some questions bubbling up for folks already. We will leave some time at the end of today's discussion to take questions from participants and invite you to use the question function or the chat if that is a little more intuitive for you to pose questions once we get to that portion of the discussion. And with that, I am excited and privileged to introduce our panelists today. I'm going to start with Chad Shearer, who is Senior Vice President for Policy and Program at the United Hospital Fund in New York, where he oversees work to build an effective and equitable healthcare system for every New Yorker. He leads work across UHF's focus areas of coverage and access, quality and equity, and clinical community partnerships, and manages a small grant program that reinforces those priorities. Mr. Shearer directs a team of experts engaged in policy and health system landscape analysis and guides programs and research to increase the quality, reliability, and efficiency of care. He also leads UHF efforts to foster healthcare and community organization collaborations to address social needs, and oversees the convening of diverse audiences to collaborate on major health policy and delivery issues in New York. Previously, Mr. Scheer was at the Princeton School of Public and International Affairs, where he served as Deputy Director of the Robert Wood Johnson Foundation's State Health Reform Assistance Network, a project that coordinated technical assistance to 11 states implementing the Affordable Care Act's coverage expansion provisions. Was also a lecturer in public affairs at the university, teaching a graduate capstone policy workshop. Mr. Scheer has also spent time at the Center for Healthcare Strategies, where he helped shape Medicaid Leadership Institute, its Medicaid Leadership Institute. And before that was a legislative director for Congressman Pete Stark, who is chairman of the Ways and Means Subcommittee on Health in the U.S. House of Representatives. And Mr. Scheer holds both law and Master of Health Administration degrees from the University of Iowa. We are also joined today by Paige Organic Lee, who is a research scientist at the George Washington University School of Public Health. Paige is a passionate health policy analyst with strong background in public health, as well as a focus on mental and behavioral health, health-related social needs, and reproductive health care. Paige has focused her research on Medicaid and related flexibilities to expand access to and coverage of health care. And Paige holds a bachelor's degree from Whitman College and master's in public health from GW's Milken Institute. And we are also lucky to be joined by Erin Kara-Kachansky, who is a research scientist also at George Washington University's Milken Institute of Public Health in the Department of Health Policy and Management. Erin is continuously striving to understand the complex healthcare and public health systems that exist in the United States and how local, state, and federal policies impact access to quality and affordable health care. Erin is dedicated to promoting systems and policies that will ensure all communities, particularly those with high degrees of health inequities, can prosper and live healthy lives. Erin holds a bachelor's degree from the Elliott School of International Affairs and master's in public health from George Washington's Milken Institute. And last but certainly not least, my colleague, Alexis Atto, is a managing director at Change Lab Solutions, where she leads a multidisciplinary team of lawyers, planners, and policy analysts in developing trainings and resources that build an equity-minded public health workforce. Alexis works on legal and policy issues related to children's mental health, the intersection of education and health justice. Alexis received her BA from Princeton University and her JD from the Washington College of Law at American University. And so with that kind of context about the backgrounds of our panelists today, I'm going to move us into some discussion to start to unpack some of the challenges we introduced during the intro presentation and really talk about some possible policy solutions. And so I'm actually going to kick us off with a question that I would love to invite all of our panelists to answer from each of their lenses, of respective expertise and experience. And so I'm going to invite everyone to weigh in a little bit here from different angles. I'm curious to hear from everyone, what are some key policy opportunities that are top of mind for you right now that can help increase access and affordability of behavioral health care? And I'm going to invite Alexis to kick us off, and then we can continue the conversation from there. Alexis?
Sure. Thanks, Christine. I think Liz did a wonderful job kind of teeing up this discussion, but I'll just re-highlight that as part of our systems level approach to identifying key policy levers that can improve children's mental health. One of the gaps that our team identified was around workforce shortages. And as Liz highlighted in her opening remarks, we know that 1 in 3 people live in a mental health professional shortage area. And we also know that access to quality, timely, and culturally responsive behavioral health care for children and families is even more limited. So really in an effort to address this gap, our work has first really focused on policy opportunities that pertain to master's level providers, so licensed clinical social workers, licensed professional counselors, and licensed marriage and family therapists, which again are among the largest occupational group of behavioral health providers and really play a critical role in delivering therapeutic services for common behavioral health challenges experienced by children and youth. And again, because these occupations are master's level professions that don't require a doctoral degree or medical degree, LCSWs, LPCs, and LMFTs have the potential to really augment the child and family serving behavioral health provider workforce. The other piece of the puzzle and kind of policy lever that we've really been focusing on are related to opportunities within the state licensure systems. So LCSWs, LPCs, and LMFTs, like other types of licensed behavioral health providers, have to follow state licensing laws that control the right to practice and define the scope of practice for each profession. And I'm happy to dig into more of the specific policy components during the rest of today's conversation, and just wanted to zoom back out to acknowledge that state licensing laws and regulations, while really important, are just kind of one piece of a very complex and multifaceted story when it comes to ensuring access and affordability in care. And I'm thrilled to be a part of today's conversation with such esteemed panelists and partners who are doing really exciting and important work to address these other complementary aspects of this issue.
Thank you, Alexis. And to speak to some of the other complex pieces of this puzzle, I'm going to invite Chad to chime in next, building off of what Alexis just mentioned, and to kind of share your thoughts.
Yeah, thanks, Christine. We've very much been thinking about this from the healthcare provider side of the equation, recognizing that we are spending a significant number of dollars on, school-based mental health, youth assertive community treatment and clinical intervention teams, and the unending acronym of existing models and programs, but we don't always know what works best for whom. And clearly, even given that investment, not everyone is getting the services they need. And thinking about where the existing, often physically focused healthcare system can help make a dent, so that we're not seeing that continuing increase in prevalence of youth mental health issues. But I will say, part of that is thinking not just about the acute crisis that we have right now in access and affordability, but also how to get upstream and focus on affordable and accessible prevention, so that next generation of children aren't just becoming the next highest bar on that longitudinal prevalence chart. And in that, we've really been looking at some of the policy and practical challenges and opportunities for better integrating care across physical, behavioral, and social care needs, but also thinking about how to do that, thinking of the family as a unit and not just the child. And I really look forward to digging in on some of that as the conversation continues.
Thank you, Chad, for that. I think we'll absolutely return to that point in a minute. And I think want to bring Erin and Paige into the conversation and share your thoughts on this in response to this question, based on your expertise and incredible research that you just completed in coordination with our team. Invite Erin and Paige, whoever's ready to hop in to take the mic.
Yeah, thanks, Christine. So Erin and I's research focus a lot on Medicaid and CHIP because it's such a large payer and it covers 42 million children. So any policy levers in this space can impact a lot of children and can improve access and affordability. So one key opportunity to attract more providers to expand access would be increasing reimbursement rates, looking at pay parity for master's level providers and pay parity between commercial payers and Medicaid. We also looked a lot at network adequacy requirements and other related regulations, because network adequacy requirements can expand access to providers within a child's network. That way they don't have to pay out of pocket. So network adequacy requirements can include provider to enrollee ratios, appointment wait times, travel time and distance standards to really reduce transportation and other barriers to accessing care for the child and their family. And we looked a lot at network adequacy requirements that can improve availability of providers and increasing regulation and monitoring of network adequacy standards in Medicaid and Medicaid managed care organizations. We also looked a lot at quality improvement efforts for states and MCOs to improve access and quality of pediatric behavioral health care. So looking at value-based payment initiatives and penalties and other incentives to both expand access, affordability, and improve quality. I think that's it from us.
Perfect. Thank you so much for that, Paige. And I want to just give a verbal plug for if any of the issues that Paige just mentioned are of interest to you participating today. There is a white paper that dives into these topics. We'll be sure to share that when we talk a little bit more about resources, but just wanted to mention that. With that, I think I want to dig a little deeper on some of the topics that you all just introduced. And I want to return to you, Alexis, on the workforce side of things and see, invite you to share specifically some key challenges and policy options that you think might be helpful in supporting the supply of behavioral health care providers to address children's behavioral and mental health based on some of the challenges you previewed in response to the previous question.
We're happy to hop in. Thanks, Christine. I think before talking about some of the specific key challenges and policy options, I just wanted to start with some brief context around how this work came about, how we identified these policy options that I'll be talking about, and want to acknowledge that this has been a multi-year and truly a collaborative effort with both former and current team members here at Change Lab, many of whom are involved in today's webinar, both on screen and behind the scenes, as well as with our CDC partners. A huge shout out to Lara's team. So we started by beginning with reviewing state licensing requirements for LCSWs, LPCs, and LMFTs in all 50 states, and also conducted a series of interviews with key experts. And what we found was that while state licenses to practice independently require kind of at a minimum some core requirements like obtaining a postgraduate degree, passing the licensing exam, and completing postgraduate supervised experience, the requirements for each license can vary greatly from state to state, as well as across licenses, even within states. And recent graduates may have little support as they navigate a complex patchwork of licensing rules. So while licensing regulations are really important for ensuring quality of care, some of the requirements can be quite burdensome and may actually deter qualified providers from entering the workforce, or can create barriers for already licensed practitioners who are trying to practice in another state. So with that context in mind, we identified 3 promising policy levers for addressing behavioral health workforce shortages affecting children. So the first is related to postgraduate training requirements, or the licensure requirements in every state that providers have to complete in order to become licensed to practice independently. So this often includes completing a minimum amount of postgraduate supervised experience. And that experience can be really valuable, a really valuable part of training for new behavioral health providers, and really important to, again, ensuring quality of care. However, there are a number of challenges of this kind of playing out in practice. One being just the hours requirements vary widely by state and by provider type. And then finding a supervisor can be really challenging. can also be quite costly for both supervisors who may not be able to be reimbursed for the time spent providing supervision, as well as for supervisees. We found that some aspiring licensed marriage and family therapists, for example, have to pay from $50 to $100 per hour sometimes for supervision, which can be prohibitive given typical annual salaries in the field, as well as things like student loan debt. In our white paper, the resources that Liz had highlighted at the beginning really provides specific policy opportunities and examples of state efforts to help offset some of the cost and time-related burdens that postgraduate training requirements can pose. The second policy opportunity to highlight relates to licensing portability processes, or the ease with which a provider who holds a professional license in one state may obtain a license to practice in another state. And again, license portability requirements are really important for ensuring quality of care. Yet again, requirements we found vary greatly. They can be difficult to find, and they can also put a particular strain on military families who are seeking care or practitioners in these families, as well as for others who may relocate frequently. Some states have adopted or are exploring streamlined licensure pathways for a provider who holds a license in one state to be able to practice in another state. This is often called reciprocity, or how they can obtain a license to practice in another state, which is often called endorsement. And then finally, just the third policy lever to highlight are related to state licensing boards, who play a key role in regulating licensing professions and shaping the workforce. How these boards are structured and function, how much authority and autonomy they have, and as well as whether their composition adequately represents the perspectives and experiences of the public, including communities most in need of behavioral health care services, are all factors that can affect the size and the quality of the behavioral health workforce. And again, the resources that we shared in the beginning of this webinar really go into some of these policy levers in greater detail.
Thank you, Alexis, for tackling that web of issues in connection with workforce and behavioral health. Really appreciate you covering both challenges and solutions, possible policy levers, really ranging from emergent, those that affect emergent practitioners, newer practitioners, and existing ones. It's all part of the puzzle. I want to revisit the topic of preventative care and turn it back to Chad. Share who you touched on this, I think, during your initial response to the opening question as far as the importance of weaving quality and affordable behavioral health care into healthcare settings and preventative care, and just want to invite you to share your thoughts on challenges to integrating behavioral health into healthcare settings and some promising models for doing so.
Yeah, and we could do a whole webinar on this, but I'm really going to focus on a few of kind of the practical and workforce realities and some of the regulatory and payment barriers specific to kind of the integration of care, starting from a base of recognizing that almost all kids visit their pediatrician pretty frequently and almost always with a parent. So an inherent opportunity where the kids are already getting seen, and there may be an opportunity to think about the family more broadly. But pediatricians have a ton of pressures, including the number of children they have to see each day and making sure that they are covering a lot of ground in each visit to fully comply, not just with, the litany of American Academy of Pediatrics guidelines at each age, but also the requirements of insurers in order to receive payment for providing those services. A couple of really, thoughtful, promising models on this front to think how to better integrate care in the pediatric practice setting. The collaborative care model is well known in adults, but more specifically for youth, the mood, anxiety, and ADHD collaborative care model is an especially promising one, but it's not easy to implement. It requires additional training, revised workflows, active external partnerships in order to ultimately be successful. And I think those are all barriers to wider adoption of that collaborative care model. we're seeing models like integrating healthy steps specialists in pediatric clinics, which are really promising from an early prevention standpoint and getting kids early before they have behavioral issues. But there are, very similar workflow and payment barriers to those non-clinical models, like the Healthy Steps Specialist. And just building a little bit on what Lara mentioned earlier, ideally, this isn't just about the kids and integrating the care for kids. It's really thinking about the families as a unit. There are some really interesting emerging models out there, 5 of which we highlighted in our 2021 report that profiled providers that are actively implementing elements of what we defined as an integrated family care model. Just a couple of those in brief, an integrated care independent provider association. So a group of providers coming together to better coordinate family services across an array of physical, mental, and social care providers. And a pediatric practice itself that actually ended up putting its practice inside an existing community-based organization focused on meeting the broader behavioral and social needs of families. Though those are really promising models, I would say insurer buy-in and payment for those models at a level that covers the full cost of care has been difficult to negotiate with insurers. On the regulatory side, some things that other people might not touch on, we are seeing growth in what is allowed to be done by the non-clinical workforce, the community health workers and, behavioral health specialists of the world, beyond the ones that Alexis talked about it. We've seen some streamlining of facility licensure rules about what can be done where and different types of facilities that can do things that may have previously been restricted to other licensing types. And really excited about the growth in some new federally supported models like certified community behavioral health clinics that I think really open the door for more integrated and holistic family-oriented care. On the payment side, which I think remains the biggest barrier, we all know mental health services are generally under reimbursed, and that makes it hard for a practice to, make the financial calculation about how they would integrate mental health into their practices. I think in a perfect world, that would happen as, a broader PMPM that would, meet the needs of the whole of the family as opposed to just the child, and think about both quality and savings from a family perspective. I'm really excited about what might be learned from some of the Medicaid waivers that have recently been approved by CMS, Oregon, Washington, New York, California, North Carolina, and Massachusetts, just to name a few. They're all really trying to figure out how to integrate care more broadly and often include significant workforce investments as well. Harkening back to the non-clinician workforce, I think insurers have started to recognize the potential role of things like community health workers that can help better integrate care. And that's something we're seeing actually play out in the waivers. So excited to see what happens there. And also, the CMS Innovation Center Integrated Care for Kids model is, thinking about how to develop alternative payment mechanisms for better integrated care for kids. And, hopefully here over the next not too long, the insurers that are participating in that will be at a point to talk about some of the alternative payment mechanisms that they've developed and what's working and what's not working. So I'll leave it there and welcome any questions.
Very much appreciate, Chad, you commenting, covering so much ground on the healthcare and payment side of things in such a short period of time, and really grateful to have you part of this conversation. I think before I touch a bit on resources that are available, I just want to make sure that folks hear a little bit about that and open it up for questions. I want to make sure Aaron and Paige have a chance to chime in a little bit, kind of continuing on the insurance healthcare side of thing, and specifically the Medicaid CHIP piece of this. I want to invite you both, either of you, to chime in a little bit on some of the the topics I think that you uplifted as part of your opening remarks related to, you touched on pay parity and the importance of that, reimbursement rates, network adequacy, and just really want to invite you to chime in on what considerations should behavioral health professionals be aware of for providing care to children enrolled in Medicaid or CHIP.
Yeah, thank you for the question, Christine. Just to take a step back and just provide some context, we looked at all kinds of publicly available Medicaid documentation across all 50 states and DC. And essentially, if you're familiar with Medicaid and CHIP, it's a complex mess. And there's no uniform management documentation across all 50 states, and even within states. As you know, that some states have managed care organizations, some states don't. So we really wanted to look at, all these documents and really understand to what degree states are referencing, including making it clear for master's level providers administering healthcare services to children on what services they're allowed to provide, in fee for service, what the reimbursement rates are going to be. In many cases, we saw that this documentation and guidance was clear, and in many cases, it wasn't clear. So for a provider looking to provide services in California, for example, you might have to navigate 2 or even 3 different types of managed care organizations. They're trying to unify that administration in California, but some states it might be one organization that you're dealing with children who are enrolled in Medicaid and CHIP, and in other states, like I mentioned, it might be multiple and organizations. And this manifests in understanding your reimbursement rate differently for different organizations and states, especially if you're providing services across state lines, and also credentialing and enrolling in these organizations. So whereas one state, you might have a credentialing requirement where you have to enroll every 3 years, you might have to pay a fee to credential in a managed care organization. Those requirements might be different across states and even within states. So it's I can imagine, I'm not a provider, but I can imagine, it's extremely difficult for providers to understand what services, to whom they're providing services to, what those requirements are across Medicaid and CHIP organizations.
I also want to chime in here. There was a lot of variations that we were seeing in statewide initiatives to recruit and train behavioral health providers. And we think that providers should be looking at their state and seeing what they can leverage. And maybe even some states could consider following other states' examples. So, for example, the Oregon State Legislature created the Oregon Behavioral Health Workforce Initiative and provided $60 million in scholarships, loan repayment programs, retention, and peer workforce development opportunities for behavioral health providers. So looking at options like that could be interesting in helping reduce barriers to creating a robust behavioral health workforce. We also want to note that for providers of all types, but especially for master's level providers, in our research and within MCO provider manuals, like Erin was saying, we found a lot of lack of clarity on what explicit services that these master's level providers could provide. So these providers should be aware that they can provide services up to their license, but also being aware of their state scope of practice and licensure requirements. And also that MCOs should be working with providers on highlighting opportunities for what services master's level providers can both provide and be reimbursed for with children.
Thank you, Erin and Paige, for sharing your thoughts and shedding light on such a complicated aspect of this, while also sharing insights on possible solutions. We have a few minutes left together. I have plenty of questions that I can continue posing our esteemed panelists. I also want to call attention to there is a question and answer function that I will invite, if you haven't done so already. Our participants should have the ability to submit questions for the panelists through that function. If you're having trouble with it, you could also drop those in the chat or whichever you feel comfortable doing. I do see one question related to workforce issues that I wanted to kind of share. And I think maybe I'll start with Alexis, but invite others to chime in. I will start by saying I don't know if we have a specific answer to this question, but do just want to, pose it for responses or insights. Lisa is asking, when we consider workforce support efforts in today's landscape, is curious if anyone has a recommended workforce ratio that would make a significant difference between prevention service providers versus staffing for acute care workforce staffing. And so just curious if anyone from the panel has thoughts on this one. I think because it's a workforce specific issue, maybe I'll start with tossing it your way, Alexis, but invite anyone to chime in and build off of that.
I have to say, I don't know if there's what that ratio would be. I was actually thinking, I bet there are folks both either on the panel or maybe even in the audience too, who may have thoughts from their work based on what they've seen. It's been kind of that ideal or recommended workforce ratio. So I'm sorry, I don't have an answer.
I can just speak to what we've seen in some of the pediatric practices here in New York. A single Healthy Step specialist or a single community health worker in a very large pediatric practice, 5,000 plus, patient practice can make a huge difference. I have no idea if, that's the ideal ratio by any stretch, though.
I think that was my my intuition as far as what I figured the response might be, but really appreciate you all sharing, you both sharing thoughts on that in response. I think I want to connect really quickly on resources because that is such an important piece of this. We've kind of previewed talking through complicated challenges and want to, before moving to close out, just give folks a chance to uplift resources that they, think might provide a little more additional information to anyone who's really excited to dig in after today's discussion. And so, Alexis, I'll start with you, and I'll also mention, I think as folks mention resources, we'll probably be sharing links in the chat that correspond to things that people are mentioning. And so have no fear if you don't have a chance to write them down. Alexis, I'm going to kick it over to you.
Thanks. So, as we've mentioned, in partnership with CDC and GW, we've recently released 3 new resources, as well as one journal article for state legislators, state licensing board members, as well as other change makers who are working to improve health for children and families. And just quick preview, together, the resources really offer kind of a nice accordion of options for folks who want to really get into the weeds of the legal analysis and findings. The journal article and the legal analysis on which that's based kind of offers that expansive approach, whereas the 2 white papers and graphic are really focused on pulling out the accessible pieces from this larger body of work and translating it into practical policy options, as well as including some of the state examples where this work is already happening.
Fabulous. Thank you, Alexis. Chad, your thoughts on resources that would be good to check out.
Well, I have a new report out today, so thank you for giving me the opportunity to talk about it. We just released a report on the ripple effects, specifically of the behavioral adolescent behavioral health crisis. I think what's new about it is really pulling together all the national data sources to look longitudinally at the impact, but then thinking about what are some of the longer term, both health and social and economic costs of adolescent behavioral health. I will drop it in the chat. I think from a solutions perspective, we were again focused on what are the non-clinical things, including, what are some of the things that can be done in the schools or in communities that can really support, beyond the four walls of healthcare providers.
Congratulations on the paper. Very serendipitous timing. Excited you get to share that with this group today. And Paige, I see you're ready to chime in here and invite you to do so.
Yeah, always excited. And congratulations to everyone. So we just are looking a lot at network adequacy standards because there are federal regulations for that sort of set a floor, but we've noticed that the National Association of Insurance Commissioners, so NAIC, has recommended network adequacy standards and has provided a model act that some states are starting to pursue and may consider adopting to ensure more robust provider networks, and especially for behavioral health providers. So I can put that in the chat, but I think that's another resource that I think could be interesting to look at to sort of increase the number of providers enrolled. And I think Aaron has something too.
Yeah, I just wanted to say, if you're a provider in a certain state or a parent of a child in this particular state, or have a particular managed care organization, it could be worth looking at the state's external quality reports that they're called, to really compare managed care organizations' quality reporting for certain care. They also note, whether the managed care organizations are doing a performance improvement project, and it might, in many cases, be particular to pediatric behavioral health. So just, if you're interested in understanding what that managed care organization is doing, it could be worth, following up on their activities.
Fantastic. Very much appreciate you all sharing your thoughts and insights and resources today. I did just want to acknowledge there was a question in the chat about connection, or not the chat, excuse me, the question and answer forum related to housing and connections to mental health. And did just want to mention our first webinar in this series was focused on was partially focused on housing issues, and so definitely we can potentially I think chat out a link to that, I believe, or can connect with you offline about sharing information about that webinar. But did just want to mention that quickly. And I think with the 2 minutes we have left, I want to move us to really wrapping up, and that's all the time we have today. I want to thank Lara, Paige, Aaron, Chad, and Alexis for sharing your insights. And I want to thank everyone who joined us today for tuning into this discussion. If you want to learn more, in addition to the resources that were just shared, we have a few uplifted on this slide. The links have been chatted to these, plus even more over the course of today's session. Moving to the next slide, we hope you've enjoyed our conversation today about opportunities to meet children's mental health needs by improving healthcare access and expanding the behavioral health workforce. Please keep an eye out for invitations to the third webinar in our series. That one will be focused on connections between children's mental health and education. And so really appreciate everyone's participation and attention today. And thank you again to all of our speakers. And I hope everyone has a wonderful rest of the day. Thank you so much.